Good evening, ladies and gentlemen. Welcome to live webinar, and this time the topic is amyloidosis. It's a case-based discussion, and we promise you it's going to be another exciting evening today. The person behind this and multiple webinars is none other than our program director, Professor Dr. B Agarwal. All of us know him. Sir is Professor and Head Department of Hematology at Bombay Hospital Institute of Medical Science, and also at Leelavati and Brij Gandhi Hospital, an institution, a teacher of teachers, multiple awards and accolades, but he's somebody who brought sanity in last 18 months to all of us by having and collaborating with stalwarts in the field of hematology across the globe. So a very, very warm welcome to you. And I would also like to have a very warm welcome to all our experts who have joined us, especially Dr. Vaishali, who is logged in from US. Over to you, sir.
Thank you, Dr. Manoj. So good evening to one and all. Our guest speaker this evening is Dr. Vaishali Sanchorwala from Boston. She's going to speak to us on AL amyloidosis, a case-based discussion. This webinar is brought to you as usual, Mumbai Hematology Group, supported by Intas, managed by Mice Ideas. I thank Dr. Manoj Kumar and his team from Intas, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group. Our guest speaker this evening, Dr. Vaishali Sanchorwala from Boston, US. All our discussants who are themselves eminent hematologists, medical oncologists, and physicians from India, and you participants for sparing your Saturday evening for academics. Discussants include Brigadier Dr. Satyaranjan Das from Pune, Colonel Dr. Sanjeevan Sharma from Lucknow, Colonel Dr. Rajan Kapoor from Kolkata, Dr. Neeraj Siddharthan from Kochi, Dr. Govind Patel from Jodhpur, Dr. Suman Pramanik from New Delhi, Lieutenant Colonel Dr. Ashok Meshram from Mumbai, Dr. Aditya Jandial from Chandigarh, Dr. Aniket Mohite from Pune, Dr. Deepankar Bhattacharya from Lucknow, Dr. Stalin Bala from Hyderabad, Dr. Rishma Roshan from Srinagar, Jammu and Kashmir, Dr. Dheeraj Bhattar from Mumbai. So you got a galaxy of discussants from all across the country today, and many of you wanted to be discussants. So that speaks of how popular Dr. Vaishali is. So today you have a giant in the field of AL amyloidosis to speak to you, Dr. Vaishali Sanchorwala. This is the second time she is doing a webinar for us in a short span of about a year. And I'm grateful to her for having accepted these invitations. To introduce her formally, and all of you know her, she's Director of Stem Cell Transplant Program at Boston Medical Center. She's Director of the Amyloidosis Center at Boston University School of Medicine, Skinner Professor of Amyloidosis Research in the Department of Medicine, Associate Editor of Amyloid, the Journal of Protein Folding Disorders, Secretary of the International Society of Amyloidosis for 2020 to 2022. Her research has led and defined the field of AL amyloidosis. And this sentence itself speaks volumes about what she has achieved. She is recognized as one of the leading international experts and a key opinion leader in this field. With numerous publications and meeting presentations, she is one of the pioneers in the field of clinical research in this field. Her work in the treatment of AL amyloidosis has resulted in the evolution of standard of care for these patients. She's currently heading several clinical trials in the treatment of AL amyloidosis, two of which were conducted nationally through SWOG 0115 and SWOG 170, led to publications in peer-reviewed journals. She's part of the faculty at major international conferences in amyloidosis and has given several invited talks in national and international meetings. She's active in various non-profit organizations, regulatory authorities, and funding bodies as an expert on amyloidosis. She is at present a member of the Executive Steering Committee of Amyloidosis Research Consortium, which is developing pathways to educate, patient voice, development of treatment, and access to novel therapies. She has helped to create and cultivate the next generation of physician scientists in the area of clinical research in amyloidosis. She regularly attends several patient information seminars and support group meetings in US. Outside of the role of direct research and clinical care, she has an interest in working for charity organizations. If you look at her educational journey, she is one of us. She educated from St. G.S. Medical College, KM Hospital, Mumbai, where she did her MBBS. She did a residency in University of Medicine Dentistry of New Jersey, fellowship in Hematology, Oncology from Boston Medical Center, and then fellowship in stem cell transplantation also from Boston Medical Center. So that has been her alma mater. I invite her to speak and deliver her lecture on AL amyloidosis, a case-based discussion. Thank you very much. Over to you, Dr. Vaishali.
So good morning, good afternoon, good evening to audience from all different time zones. I would like to begin by thanking Professor Agarwal for inviting me here to speak on the update on current therapy for AL amyloidosis, a case-based approach. We will be beginning our presentation with few cases, and I would like to now first give you. Hold on, I can't advance the slides, hold on. Are you able to see my screen?
Yes, ma'am.
Okay. So I would like to begin by showing you my disclosures. These are my disclosures. I get research support from several pharmaceutical companies. And I think my biggest disclosure is that I'm a transplant physician. I do stem cell transplants. And you will see when we present the cases, what I mean by that. So we are going to begin by case 1, which is a 48-year-old woman with AL amyloidosis diagnosed by renal biopsy when she presented with leg swelling and proteinuria. Her renal parameters at the time of diagnosis revealed low serum albumin of 2.8 grams per deciliter, normal renal function with serum creatinine of 0.8 milligrams per deciliter, 24-hour urine protein excretion of 7 grams per day, and her estimated glomerular filtration rate was 75 ml per minute per meter square by CKD epi formula. This placed her into renal stage 2 disease based on 24-hour urine protein excretion of greater than 5 grams per day and EGFR of greater than 50 ml per minute per meter square. Her cardiac parameters were NT-proBNP of 600 picograms per ml, BNP of 200 picograms per ml, troponin I of 0.01 nanograms per ml, and left ventricular ejection fraction of 55% normal, and New York Heart Association class 1. This placed her into cardiac stage, Mayo stage 2 disease because of elevated NT-proBNP greater than 332 and troponin I, which was normal, and Boston University staging system, BNP greater than 81 and normal troponin I. Her markers of plasma cell dyscrasia revealed elevated free lambda light chains at 220 milligrams per liter, free kappa light chains normal at 20 milligrams per liter, with a ratio which was abnormally low, favoring lambda at 0.13. Bone marrow biopsy showed 5% lambda typic plasma cells with normal cytogenetics and FISH. Immunofixation electrophoresis of urine showed free lambda light chain protein. So what is the best option for this young 48-year-old lady for treatment of her AL amyloidosis? And the options are oral melphalan dexamethasone, the Italian regimen, high-dose melphalan and stem cell transplantation, cyclophosphamide, bortezomib, dexamethasone, subcutaneous daratumumab and cyclophosphamide, bortezomib, dexamethasone, or RVD, lenalidomide, bortezomib, dexamethasone. I would give you a few seconds to just think about this, and then I will tell you what my preference would be or what my answer would be. So I would choose high-dose melphalan and stem cell transplant for this young patient who is relatively asymptomatic with renal stage 2 and cardiac stage 2 disease. High-dose melphalan and autologous peripheral blood stem cell transplantation was developed for the treatment of AL amyloidosis at Boston University in early 1990s. Development of this treatment approach was prompted by promising results of similar treatment regimens in multiple myeloma. Objectives of the initial clinical trials were to determine tolerability of this aggressive treatment approach in patients with multi-system organ dysfunction from AL amyloidosis. The second objective was to determine efficacy of this treatment in inducing complete hematologic response, and we hypothesized that because the plasma cell burden is low in patients with AL amyloidosis, this treatment would be highly efficacious, maybe even more than multiple myeloma, in inducing complete hematologic response. And finally, to determine whether complete hematologic response leads to reversal of amyloid-related disease and improve survival and improve organ dysfunction. 629 patients with AL amyloidosis have undergone autologous peripheral blood stem cell transplantation following high-dose melphalan at Boston University and Boston Medical Center. Hematologic complete response was achieved in 40% of patients at 6 to 12 months following transplant. Patients who received full high-dose melphalan at 200 milligrams per meter square had a higher chance of achieving a complete hematologic response at 45% compared to 34% for those who received modified high-dose melphalan at 100 to 140 milligrams per meter square. Organ responses were also evident after stem cell transplantation. Organ responses with respect to renal response, cardiac response, and hepatic response occurred in those who achieved a hematologic response, a complete response, and also was achieved for those who achieved a very good partial response or partial response following stem cell transplant. It is important to note that hematologic complete response is not always needed to achieve an organ response. Furthermore, organ response lags behind hematologic response by 6 to 12 months. Median overall survival for the 629 patients who have undergone high-dose melphalan stem cell transplant was 7.6 years. 30% of the patients achieved a long-term survival of greater than 20 years with a plateau in the survival curve after 15 years. This data was also represented by the CIBMTR experience, where greater than 1,000 patients had undergone stem cell transplantation for AL amyloidosis, showing improvement in 5-year overall survival with reduction in treatment-related mortality from early 1990s to mid-2000s, and 5-year overall survival improving from 55% in mid-1990s to 77% in 2000s. Mayo Clinic investigators have also reported on their experience showing an estimated 15-year overall survival following stem cell transplantation for AL amyloidosis in 33% of the patients. UK National Amyloidosis Center reported on their experience of 264 patients undergoing stem cell transplant for AL amyloidosis, showing a median overall survival of 8.2 years with 33% of the patients achieving a long-term survival at 20 years. There are no prospective randomized clinical trials of high-dose melphalan and stem cell transplant versus oral therapy for AL amyloidosis, except for this trial published in the New England Journal of Medicine from the French group, which was an intergroup French trial where 100 patients with newly diagnosed AL amyloidosis were randomized to receive high-dose melphalan stem cell transplant versus oral melphalan dexamethasone, showing a survival advantage for melphalan dexamethasone and survival disadvantage for high-dose melphalan stem cell transplant. This trial has been criticized because 17 centers were involved for this intergroup study, and there was an increased treatment-related mortality with high-dose melphalan stem cell transplant of approximately 24%. And those who were randomized to receive stem cell transplant did not end up getting stem cell transplant because of issues and complications during stem cell mobilization and collection. This is a natural history study of Boston University of 40 years of experience of stem cell transplant and non-stem cell transplant regimen. Let's focus on the most contemporary era of 2010 to 2019, era 4. And as shown here, five-year overall survival was 76% for those who were treated with stem cell transplant, and it was 42% for those who were treated with non-stem cell transplant regimens. It is important to note this is not a randomized study, but this is a natural history study from our clinical database of approximately 3,000 patients who were treated with various treatment regimens depending on the different era and availability of treatment from 1980s to 2019. Similar results were also reported by the Mayo Clinic investigators, again focusing on the contemporary era of 2010 to 2014. Two-year overall survival was a 94% for those who received stem cell transplant and 47% for those who received non-stem cell transplant regimens. Similarly, progression-free survival from the Mayo Clinic cohort also showed that two-year progression-free survival for the contemporary era was 73% for those who underwent stem cell transplant and was 30% for those who had non-stem cell transplant regimens. Mayo Clinic investigators have also reported that bone marrow plasmacytosis affects survival in AL amyloidosis. Patients who have greater than 10% and even importantly, greater than 20% plasmacytosis have poorer survival following treatment. We looked at role of induction therapy prior to stem cell transplantation in AL amyloidosis based on plasmacytosis and did not see any difference as demonstrated on the left panel. When we looked at induction therapy for those who had received induction therapy prior to stem cell transplant for bone marrow plasmacytosis of greater than 10%, we did not see any difference in overall survival, statistically not significant. Let's move on to case number 2. It's a 68-year-old woman with AL amyloidosis diagnosed by renal biopsy when presented with leg swelling and proteinuria, similar to our case 1, however, a little bit older. Her renal parameters were low serum albumin at 2.8 grams per deciliter, serum creatinine that is elevated at 2.5 milligrams per deciliter, and 24-hour urine protein excretion of 7 grams per day. Her estimated GFR is 16 ml per minute per meter square by CKD epi formula, and this places her in renal stage 3 disease based on 24-hour urine protein excretion greater than 5 grams per day and EGFR less than 50 ml per minute. Her cardiac parameters are NT-proBNP of 6,000 picograms per ml, BNP of 700 picograms per ml, troponin I, which is elevated at 0.1 nanograms per ml, and left ventricular ejection fraction of 55% normal, but New York Heart Association class 2. So this places her into Mayo stage 3 disease based on elevated NT-proBNP and elevated troponin I, and Boston University stage 3 disease as well, because BNP greater than 81 and troponin I also greater than 0.1. Her markers of plasma cell dyscrasia are similar to our first case, with free lambda light chains of 220 milligrams per liter, free kappa light chains normal at 20 milligrams per liter, with an abnormally low ratio favoring lambda clonal plasma cell dyscrasia. Bone marrow biopsy, 5% lambda typic plasma cells with normal cytogenetics and FISH, and immunofixation electrophoresis of urine with free lambda light chain protein. So what is the best option for treatment for this individual? And the options are oral melphalan and dexamethasone, high-dose melphalan and stem cell transplantation, cyclophosphamide, bortezomib, dexamethasone, VCD or Cybor-D, bortezomib, melphalan and dexamethasone or BMD, and RVD with len, bortezomib, dexamethasone. And my choice would be bortezomib, melphalan, dexamethasone. And I will go over why I chose this option versus Cybor-D. And let's move on to talk about some non-stem cell transplant regimens. Again, I will keep repeating myself. We do not have many randomized clinical trials to assess the role of stem cell transplantation in AL amyloidosis. The standard non-stem cell transplant regimens up till now used to be oral melphalan dexamethasone and combination of cyclophosphamide bortezomib dexamethasone. These are two pivotal studies from the European groups looking at 259 patients treated with oral melphalan dexamethasone not eligible to receive stem cell transplantation. When patients received weekly low-dose dexamethasone, complete hematologic response in this study was 12%. 230 patients with AL amyloidosis not eligible to receive stem cell transplant from the European cohort were treated with Cybor-D, and when weekly Cybor-D was administered, when weekly bortezomib was administered, the complete hematologic response was 19%. For the oral melphalan dexamethasone cohort, when dexamethasone was used as a weekly low-dose regimen with 20 milligrams or 40 milligrams weekly, the median overall survival was 20 months as shown in the left panel, and with a median follow-up of 25 months for the Cybor-D cohort, the 3-year overall survival was 55% with a median progression-free survival of 13 months. UK National Amyloidosis Center reported on 915 patients treated with upfront bortezomib therapy, and the hematologic complete response was noted in 25% of the patients, with very good partial response in 20% of the patients. And with the median time to next treatment was not reached, and the median overall survival was 72 months in this cohort. European Myeloma Network performed a randomized clinical trial of 109 patients treated with bortezomib melphalan dexamethasone versus oral melphalan dexamethasone. And as shown in these panels, the overall hematologic response, combination of very good partial response and complete hematologic response, overall survival, and progression-free survival were in favor of bortezomib melphalan dexamethasone compared to melphalan dexamethasone. The safety run-in results of the Andromeda clinical trial was reported in 2020, which enrolled 28 patients with newly diagnosed AL amyloidosis treated with Cyborg-D or VCD plus subcutaneous daratumumab. And as you can see in these slides, the hematologic complete response, hematologic very good partial response, overall hematologic response, and even organ responses were unprecedentedly high. 97% of the patients achieved a hematologic response on this safety run-in results. This trial has completed accrual and has been analyzed and was recently reported in the New England Journal of Medicine, showing 388 patients randomized to receive Cyborg-D plus daratumumab versus Cyborg-D alone, and hematologic responses and major organ deterioration progression-free survival were in favor of Dara-Cyborg-D arm compared to Cyborg-D alone arm. Cyborg-D was delivered for 6 months and daratumumab was given as maintenance therapy for a total of 24 months. This trial has a median follow-up time of 14 months and is ongoing for analysis of overall survival. Median time to response was 60 days, very rapid with Dara VCD or Dara Cyborg-D arm compared to 90 days for Cyborg-D or VCD arm. Let's move on to case number 3. It's a 56-year-old man with AL amyloidosis and renal and cardiac involvement who underwent high-dose melphalan stem cell transplant in 2005 and has achieved a hematologic complete response as well as organ response. He experiences relapse of plasma cell dyscrasia as well as organ biomarkers in 2020, 15 years after stem cell transplantation. At the time of relapse, his renal parameters include serum albumin of 2.8 grams per deciliter, serum creatinine is 1.2 milligrams per deciliter, and 24-hour urine protein excretion of 5 grams per day. His cardiac parameters include NT-proBNPs 600 picograms per ml, BNP which is elevated at 200 picograms per ml, and troponin I of 0.01 nanograms per ml with normal left ventricular ejection fraction and relatively asymptomatic from New York Heart Association class. Markers of plasma cell dyscrasia are listed over here with mildly elevated free lambda light chains, normal free kappa light chains with abnormally low ratio with difference between involved and uninvolved light chains of 50 milligrams per liter. So we would talk about the pivotal trial, which was a global multi-center single agent trial of bortezomib in relapsed refractory AL amyloidosis, CAN 2007. The key points of this trial were that single agent bortezomib produces durable hematologic responses and promising long-term overall survival in relapsed patients with AL amyloidosis. Furthermore, once-weekly bortezomib is better tolerated and produces similar responses to twice-weekly bortezomib, especially in patients with relapsed AL amyloidosis. We at Boston University performed a pooled analysis of immunomodulatory agents of 3 clinical trials of lenalidomide dexamethasone, melphalan lenalidomide dexamethasone, and pomalidomide dexamethasone used for patients with relapsed AL amyloidosis, and a total of 125 patients. I would like you to focus on the survival at the bottom. The median overall survival for patients who were treated with immunomodulatory agents for relapsed AL amyloidosis was 4.3 years, and the median progression-free survival was 2.1 years. This is the Tourmaline AL1 trial, phase 3 global multi-institutional randomized trial of oral proteasome inhibitor ixazomib dexamethasone versus physician's choice of therapy, which included thalidomide dexamethasone, cyclophosphamide dexamethasone, lenalidomide dexamethasone, dexamethasone alone, or melphalan dexamethasone. Unfortunately, this trial was a negative trial and did not meet its primary endpoint of overall hematologic response. However, if you look at complete hematologic response, median duration of hematologic response, vital organ progression-free survival, and hematologic progression-free survival, it favored ixazomib dexamethasone arm. However, this trial did not complete accrual because it did not meet its primary endpoint of overall hematologic response. Monoclonal CD38 antibody daratumumab has been a game changer in patients with AL amyloidosis. Two prospective clinical daratumumab given intravenously was performed in patients with relapsed AL amyloidosis, one at Boston University and other one in France. And as you can see, the hematologic response rate, including complete and very good partial responses, were unprecedented in relapsed AL amyloidosis when treated with single agent daratumumab. Furthermore, hematologic progression-free survival for patients treated with daratumumab was about 2 years, 2.5 years. This was an editorial published by Dr. Dispensary in Blood, which gives you a flavor of two prospective trials and several other retrospective trials, as well as its role in daratumumab as single agent in relapsed refractory myeloma as well. SWOG 1702, which is a clinical trial for isatuximab, which is another anti-CD38 monoclonal antibody, has completed accrual. And my colleague Terry Parker reported this at the International Society of Amyloidosis in 2020 and is going to update the analysis at ASH 2021, showing that isatuximab given intravenously is well tolerated in patients with relapsed refractory AL amyloidosis, with infusion-related reactions occurring in about 50% of the patients, mainly grade 1 or 2. And the safety data is comparable to that of daratumumab therapy, ranging from 22 to 60%. Respiratory infections were reported in 59% of the patients and 32% of patients in the two prospective trials with daratumumab. So, the safety profile is quite similar to daratumumab. We will await the results of the updated analysis with response rates and long-term outcome. Bendamustine, an alkylating agent, which is usually used in lymphomas, has also been studied in a small phase 2 trial, which was another multi-institutional trial of 28 patients with relapsed AL amyloidosis, showing 11% complete hematologic response and 18% very good partial response, with a median overall survival of 18 months. And those who achieved a hematologic response had a better overall survival compared to those who did not achieve a hematologic response. Venetoclax, a small molecule BCL2 inhibitor, has also been studied in AL amyloidosis, hypothesis being translocation 1114 is commonly present in patients with AL amyloidosis, approximately 40 to 50% of the patients, and hence this was a multi-center retrospective analysis of the efficacy of venetoclax in AL amyloidosis. And again, as shown here, patients who harbored translocation 1114 had a response rate of 78% VGPR and CR. AbbVie is designing clinical trials of venetoclax in patients with relapsed AL amyloidosis, either as single agent or in combination with daratumumab. Those trials are not yet accruing or ready for enrollment. So for our patient case 3, the treatment options in this day and age are really, really wide. The treatment armamentarium and paradigm has significantly expanded in the last decade for patients with AL amyloidosis. There are several clinical pearls that I would like you to note. Daratumumab does have infusion-related reactions, specifically when given as intravenous infusions. We now in the United States have completely changed it to subcutaneous administration, and the administration-related reactions are negligible. It is important to also note that the respiratory infections can occur grade 3 and 4 in 18 to 20% of the patients in 2 prospective clinical trials. Immunomodulatory agents, pomalidomide or lenalidomide, the clinical pearl to remember is that there is paradoxical increase in cardiac biomarkers. 80% of the patients will have 30% increase in the cardiac biomarkers, and hence it becomes difficult for assessment of cardiac response. Moreover, there is worsening of renal function that was seen in prospective trials at our institution in almost a quarter to 2/3 of the patients, and 10% required dialysis. Most of the times, this acute worsening of renal function is reversible after stopping immunomodulatory agents. Ixazomib, also based on the Tourmaline AL1 trial, can cause skin rash, fatigue, and diarrhea, and this needs to be taken into account. Last case number 4, is a 68-year-old man of African descent who presented with new onset of heart failure in 2015. His echocardiogram revealed an interventricular septum in diastole of 18 millimeter, so this was significantly thick, with a left ventricular ejection fraction, which was low at 35%. He underwent a coronary angiogram and had no obstructive coronary artery disease. Cardiac MRI, almost a year later, showed late gadolinium enhancement, and his plasma cell dyscrasia marker, because of this cardiac MRI report suggesting infiltrative gammopathy on serum and urine immunofixation electrophoresis, serum free kappa light chain levels were mildly elevated with a ratio that was 1.99 out of the range of upper limit of normal, and the bone marrow biopsy showed 5% plasma cells with kappa predominance. Abdominal fat pad aspiration revealed Congo-red positive amyloid deposits. So patient was diagnosed with systemic AL amyloidosis with a cardiac involvement. In June of 2016, after the diagnosis, he was treated with 4 cycles of cyclophosphamide, bortezomib, dexamethasone, standard of care treatment in 2016 at an outside institution. Due to lack of response and worsening of his congestive heart failure symptoms, he was referred to Boston University Amyloidosis Center in November of 2016. We ended up recommending a cardiac biopsy because I will tell you what the thinking was, and the amyloid protein analysis by mass spectrometry, liquid chromatography, tandem mass spectrometry showed transthyretin to be the precursor amyloid protein. And the DNA analysis revealed that the transthyretin protein had a mutation of valine 122 to isoleucine variant. Therefore, this gentleman had ATTR amyloidosis due to V122I variant with an unrelated monoclonal gammopathy of unknown significance. Few words on ATTR mutant amyloidosis due to V122I, that there is a valine to isoleucine substitution at position 122 of the transthyretin gene. It is almost exclusively affects patients of African descent. It is prevalent in 3 to 4% of Black Americans and up to 12% of Afro-Caribbean patients over the age of 60 would have congestive heart failure would have this mutation. So monoclonal gammopathy of unknown significance is present in 23% of patients with wild-type ATTR amyloidosis and 39% of patients with wild-type TTR at our institution have also monoclonal gammopathy of unknown significance. This is much higher than patients in general, MGUS in general population of 1 to 2%. Monoclonal gammopathy is present in almost half of the patients with V122I ATTR amyloidosis. And this was published from our institution in 2018. So the bottom line is that not all amyloidosis as it seems. The presence of a monoclonal protein does not guarantee a diagnosis of AL amyloidosis. One has to take into account the clinical parameters, clinical syndromes, and the overall picture, and the amyloidogenic protein identification is crucial and fundamental. Furthermore, existence of one type of amyloidosis does not make one immune to other types of amyloidosis. We have had patients who were diagnosed with AL amyloidosis 20 years ago and have remained in complete hematologic response, now presenting 20 years later with congestive heart failure at the age of 75 and have been diagnosed with ATTR wild-type amyloidosis. So it is very, very important to remember that experience in this rare disease is quite important. And I would like to conclude by acknowledging many members of our basic science team and our clinical team who have participated in generating all this data and remain on the scenes and behind the scenes to take care of these critically ill patients. Thank you for your attention, and I would be happy to take questions and we will proceed with discussion.
Thank you, Dr. Vaishali Sanchorwala. That was beautiful. 4 cases, 4 types of presentation, and 4 different approaches with review of all the research data from your center and from the world. It was very educative. So we've got all these Indian faculty here, and they will have some of their difficulties. We will use the raise hand sign to pick up those who want to ask something. Meanwhile, I'll put up a question from the audience. In non-transplant eligible patient with 6 months of CyBOR-D, patient still has significant proteinuria. How will you manage further? How long will you continue CyBOR-D before you say that the treatment has failed?
So, excellent question. I did this talk in January, and my email to Professor Agarwal in January was that I was totally stunned and amazed at the questions. I said it was not just fun to deliver the lecture, but it was so much fun to answer the questions from the panel, from the audience, because everybody has dealt with this. Everybody has put in effort to ask questions, and I'm absolutely honored and privileged to be here to answer these questions, because we all are here to help our patients. Let me begin by stating D is a plasma cell dyscrasia treatment. What is deposited in the organs is extracellular, pathologic, insoluble amyloid fibrils, amyloid deposits. CyBOR-D is not attacking this pathologic amyloid deposition. So I think that if you've done 6 cycles of CyBOR-D, my question to you would be, what is the hematologic response? The hematologic response, if the patient has achieved a complete hematologic response defined as normalization of serum free light chains, normalization of serum free light chain ratio, and absence of monoclonal protein in immunofixation electrophoresis, I would stop after 6 months. It is important to support this patient with symptomatic management because the organ response takes 10 to 12 months to occur. And the organ response is defined as 30% reduction in proteinuria. So if the patient has 5 grams of proteinuria, 30% reduction is going to be 4 grams, 3 grams. I can't do math, but it would be 4 to 3 grams of proteinuria. It is not going to be normal. Or normalization of proteinuria, symptomatic management would be avoid nephrotoxic agents. Nobody should give them intravenous contrast for CAT scans. Nobody should give them non-steroidal and anti-inflammatory agents. Nobody should give them Bactrim, things like that, Bactrim or sulfamethoxazole. So I think that, it is important to manage them symptomatically, but focus on the hematologic response first. The proteinuria will respond if you have achieved a complete hematologic response.
Dr. Sanjeevan Sharma, your question.
Hi, good evening, Dr. Vaishali. An absolutely fantastic lecture. And I'm happy because you started a disclosure by saying that you're a transplanter, and my question actually revolves around the difficulties which I faced during transplant of a few patients of AL amyloidosis. Actually, these were all in my previous hospital, where now my senior Dr. Satyaranjan Das is heading that, and he's also a part of the panel. So in the period between 2016-17, we did 4 AL amyloidosis transplants, and we unfortunately lost 2 of them. And both of them, the first one was a young 32-year-old man who had a predominantly GI manifestation. He presented with diarrhea. He had on a rectal biopsy, he had a congruent positive amyloid. And in addition, he also had AL amyloidosis by the various parameters. We took him up front for high dose 200 milligrams of meter square melphalan transplant. And he had a horrendous mucositis, and eventually at autopsy, they realized that his entire upper gut, including his duodenum, his stomach and everything, the submucosa was infiltrated with the amyloid. And they said probably the high dose melphalan as such causes mucositis. There it has also the amyloid deposition there probably led to such a severe refractory kind of a mucositis and sort of this thing. So my first question is that, would you in a person also consider doing an upper GI endoscopic biopsies before you would decide to take up such a patient for transplantation? And in case if the submucosa is heavily infiltrated with amyloid first, would you like to give them some therapy, or would you directly take up for transplant?
Right, great question again. So we are developing guidelines for stem cell transplantation in AL amyloidosis through International Society of Amyloidosis. It is going to be published in the Amyloid Journal, and we also have a webinar. So transplantation for AL amyloidosis is not easy. So I make this joke to everybody that I must have been an intensive care unit doctor in my past life, because that it is intense. Patients do not do well because it's not like myeloma transplants, which is fun to perform, because these patients their organs are beat up and it is very difficult. We generally suggest that if they have extensive GI involvement, so yes, we would do upper endoscopy, lower endoscopy, both. And if they have evidence of GI bleeding, we check their stool for occult blood. If they have evidence of GI bleeding or iron deficiency anemia, we would not recommend to perform stem cell transplant for the reasons that you are suggesting, because melphalan can cause significant mucositis, and it is very difficult for these patients to we have lost several patients as well to GI bleeding, massive GI bleeding and then, it is loads and loads of blood product support, and their hearts cannot handle it. So again, that it is a known complication. Again, if it is extensive GI involvement, probably it may not be unreasonable to do something non-transplant based. And that we now have such effective therapies with Cyborg plus Dara that, generally speaking, patients tolerate it much better than stem cell transplant.
And Dr. Vaishali, the second patient whom we lost, and he was a young male. This time he had extensive peripheral, autonomic neuropathic symptoms. His baseline blood pressures used to remain systolic 85, 88. But because his other organ systems, so we had a tumor board meeting in which the nephrologist, and he had a proteinuria of almost 7 grams, the kind of first case number 1 which you presented. Absolutely normal heart. In fact, PU cardiac score would be 1 because the pro-BNP was not elevated, TROP-I was normal, ejection fraction was good. Only he had a bad autonomic neuropathy and proteinuria of 7 grams. So we took up this patient for transplant. And then again, we just couldn't get him out of the severe septic shock that he went in, because baseline blood pressures of around 80 systolic. And when during the sepsis, he just, went through. So these are these learning points that other things may be good, but if other organs like a GI or an autonomic neuropathies are also involved, should we be urging caution rather than just looking at the age, looking at the performance history, and going ahead with a transplant? Thank you.
So, I obviously did not have time. I think I don't remember whether in January I did present the exclusion criteria or not. Systolic blood pressure less than 90 in supine position is, we do not transplant these patients because of this autonomic failure that happens, and I think that there was one abstract of melphalan in multiple myeloma leading to vascular tone related issues. That, again, that we do see that patients who are hypertensive and on antihypertensive regimens post melphalan, even for myeloma, they come off their antihypertensive regimens, because I think something does happen to the vascular tone. And I think the patients who are refractory autonomic failures or autonomic neuropathy with low systolic blood pressures of less than 90, we would not transplant them. Just because, I think that it is so difficult for them to get through it. Again, bortezomib Velcade can also cause unmasked autonomic neuropathy. So these patients are extremely challenging. Now with daratumumab, what I have been doing for these patients is doing single agent dara up front with the hope that I can maintain their blood pressures. They achieve a hematologic response, and then the autonomic neuropathy would get better. The other symptomatic management, I think that is also that, again, I'm not sure what is available in India, but what we do here is we put them on midodrine, which is an alpha-1 agonist, which causes vascular vasoconstriction to raise blood pressure, and it is approved for diabetic autonomic neuropathy. But we use a lot of it here during transplant. The maximum dose is 15 milligrams 3 times a day, but I have used in amyloid autonomic neuropathy 20 milligrams 4 times a day. We also use a lot of fludrocortisone or fluororinef, which is another, a mineralocorticoid, which will cause sodium retention and raise the blood pressure. Again, when patients are hypoalbuminemic and nephrotic syndrome, fludrocortisone is probably not the best choice because it will worsen peripheral edema. We have also started using something called droxidopa, which is extremely expensive in the United States to use, but that again can cause increase in blood pressures. So I think that the supportive care management during, and that is what these guidelines are going to talk about when the reviewers feel that it is ready to go, because this is the third time the reviewers have sent it back, So I'm going to hopefully have it published soon. But, I think that the supportive care is absolutely critical in success of stem cell transplant for AL amyloidosis.
Thank you, Dr. Sanjeevan. Dr. Reshma, you be ready with your question. And one audience question is, how do you decide whom to debulk before transplant? Whom do you take up directly for transplant? And whom do you give the medical treatment before transplant?
So I think that the question is about induction therapy. So there is some debate over this, because if you hear from the Mayo Clinic group, they always want to give induction therapy. I also didn't present that data because of time constraints, but I think in January we had talked about it. So there are 2 clinical trials of induction therapy with bortezomib dexamethasone, one from my institution, one from HOVON group, HOVON 104 trial. Both these trials had induction therapy with bortezomib dexamethasone 2 to 4 cycles respectively, followed by stem cell transplant. Unprecedentedly high hematologic response rates of 60-70% CRs. But in both the trials, in my trial, it was 14%. In HOVON trial, it was 30% of patients who were deemed eligible to undergo stem cell transplant became ineligible during induction therapy. One of them developed syncope because it was passing out, unmasking of autonomic neuropathy, and just could not, a performance status worsened and was not able to undergo stem cell transplant. One person developed worsening renal failure. One person developed worsening congestive heart failure. So again, 14 to 30% of the patients who are eligible become ineligible during therapy. So I think one has to keep that in mind. Plasmacytosis of greater than 20%, I would do induction therapy with 2 to 4 cycles of bortezomib-based therapy. And then take them to transplant. There are some patients who achieve a complete hematologic response after 2 to 4 cycles of bortezomib-based therapy. I do not then take them to transplant because you don't want to kill a patient in hematologic complete response. If they achieve hematologic complete response with induction therapy, I think I would continue induction therapy for 6 cycles or complete it, whatever. Mayo Clinic, University of California, San Francisco, or Stanford, they have a different approach because we have to get insurance approval for stem cell transplant. And in my institution, we are very quick. We can get it done within 4 to 6 weeks. I think at other institutions, it takes them a longer time, and they are performing induction therapy for all patients with AL amyloidosis. So they have 4 months to obtain insurance approval and then take them to transplant. And I think with SIBO-D-DARA, again, I think that the responses, hematologic responses are such high that role of stem cell transplant is evolving, because if they are treated with SIBO-D-DARA, majority of the patients are going to be in hematologic response, CR or VGPR, by the time they get to you. And I think those patients I don't transplant, I wait for them to relapse 2 years, 3 years, 4 years. Now, the role of transplant is definitely going to evolve over the next 5 years.
Thank you. Dr. Reshma, your question.
Good evening, Dr. Sanchorwala. Thank you for such a nice presentation. My question is, many of our patients present with concomitant myeloma, they fulfill all the criteria for CRAB. Usually, amyloidosis is missed at presentation. Subsequently, during the induction, they present either with swelling of feet, and then we go back and look for amyloidosis. And yes, many times we subsequently diagnose them with amyloidosis. And many of such patients are very high burden. Like right now, I have a patient who had 60% plasma cells at presentation, and now subsequently 3 cycles down the line, she is amyloid in the kidneys. So my question is, in such patients, like if we diagnose upfront, in addition to induction, does doxycycline still has a role for whatever earlier it was supposed to prevent the deposition of the amyloid or something with the amyloid deposition? And does the management in such patients differ anyways, other than the simple amyloid like induction followed by transplant, or do we have to do something different in such patients?
So again, great question. Myeloma-associated AL amyloidosis, commoner than we think. I think the 2 issues. The first one is the induction. I would not do RVD induction. I would not do lenalidomide, bortezomib, dexamethasone. That I would generally do for multiple myeloma. But when there is myeloma-associated AL, I would still stick with SIBO-D plus daratumumab if it is available. I would do that induction because I think that the tolerability is so much better. Lenalidomide at 25 milligrams or even 15 milligrams or even 10 milligrams is very, very difficult for patients with AL amyloidosis, specifically in the newly diagnosed setting, to tolerate. So I think that the induction therapy would be different. I would probably do CyBO-D-based induction. The second question is about doxycycline. So again, a bit of a controversy, but I think that, again, maybe not a bit of controversy, that doxycycline was shown in our institution in animal models to dissolve, quote unquote, amyloid deposits. It was done in Dr. David Selden's laboratory here at Boston University, that mice who were fed water with doxycycline, and after they were sacrificed, the amyloid deposition in their GI tract was less or negligible than those who were fed water alone. This was then taken into phase 2 trial. This was taken into some phase 3 trials. And I think the trials from UK National Amyloidosis Center, not the trials, it was a retrospective case-based control study suggesting that when doxycycline is used in patients with advanced cardiac amyloidosis, along with plasma cell dyscrasia directed therapy, it improves survival. It was compared to historical controls. So it was not a randomized clinical trial. Dr. D'Souza from Medical College of Wisconsin has published their experience as a phase 2 experience without, again, compared with historical controls, that yes, doxycycline does have rapid organ responses. Again, not shown in randomized clinical. There is a clinical trial ongoing in Europe. That doxycycline also has lots of side effects like GI toxicity. One of my patients kept saying, he was a man, 35 years old, and he kept saying that I feel like I'm having morning sickness. Every morning I have very bad nausea, vomiting, and he stopped taking it after 3 to 4 months because he just couldn't tolerate it. Furthermore, there is also a lot of issues with photosensitivity. Patients in London can tolerate them because there is no sun. In patients in India and Boston, where we have a lot of sun, they really cannot tolerate it because there is a lot of photosensitivity. One of them developed significant skin burn on doxycycline. Again, I think, we have darker skin, so I don't know what photosensitivity in patients of Indian origin would be, but definitely I think that is a realistic concern. So we don't generally use doxycycline. I have used it in advanced stage 3B cardiac amyloidosis, but it doesn't work on its own. It has to be combined with antiplasma.
Thank you. Neeraj, be ready with your question. And meanwhile, there's a question from Dr. Rajiv Kumar. What is the role of SAT scan before starting treatment of AL amyloid?
Again, folks are asking all controversial questions here. And amyloid is a very small world and we are all friends, but we all have our issues. So I'm sure Dr. Wecklecker from National Amyloidosis Center, ASHU, has talked about SAP scan. So SAP scan, the radionuclide, is not available in the United States of America. FDA has not approved the serum amyloid P protein radionuclide here. It is performed only at UK National Amyloidosis Center. It is not performed anywhere else in Europe. I think that, again, it's a good scan if you know how to do it. It's a good scan if you have it. It does not delineate heart. It does not tell you whether heart is involved or not, because SAP will not stick in the heart because the blood is just constantly flowing from the heart. So it doesn't really work. It tells you about liver. It tells you about spleen. It tells you about kidneys. It tells you about soft tissues. But we have other parameters to figure out whether they have liver involvement. We have physical exam. We have alkaline phosphatase. We have other parameters to figure out renal involvement. We have creatinine, albumin, 24-hour urine collection. I can feel a spleen better than SAP scan because I am a good physical exam person from SET GS Medical College. So, personally, I don't really feel that SAP scan is indicated. I think it is a good test to really also do what is the response to treatment. Whether after treatment, whether the SAP scan gets better. But again, what difference does it make if a 24-hour urine protein collection has dropped from 7 grams to 400 million? Patient is feeling better, patient is doing better, kidney function is normal, proteinuria has decreased. So I think it is an academic test. That is where I would stop. Ash is going to chop my head off.
Go ahead. Dr. Neeraj, your question.
Thank you, sir. Good evening, Dr. Vaishali. Thank you for that excellent review of that very rare disease. I have two questions on cardiac amyloid and one question on role of maintenance in AL amyloid. Regarding the cardiac amyloid, for a young patient who is transplant eligible, and let's say if you had given us a scenario of a stage 2 cardiac, suppose it's a higher stage in the beginning, like let's say stage 3, and what would be the criteria to take up the patient for an autologous transplant? Would you give an induction? Sometimes we have seen cardiac functions improve after an induction, and would that be the option, or would you straight away take up for the autologous transplant in the beginning? That's one question. And second is, sometimes we have patients presenting with AL amyloid and advanced cardiac involvement, where even if you achieve a hematologic response, the patient, it doesn't translate into a survival for the patient. So how do we deal with that? And the third, of course, is like in multiple myeloma, would you be giving us guidelines for maintenance in AL amyloid? Thank you.
Obviously, excellent questions. These questions are controversial. These questions also have a lot of knowledge versus experience. We all treat them differently. We all treat them with great caution. The first question is about cardiac amyloid and stem cell transplant. So it all depends on how severe the cardiac involvement is. And besides just looking at the patients, there are several other objective findings that can help us assess whether patient is transplant eligible and whether patients would survive stem cell transplant. So the first is the cardiac biomarkers. So Mayo Clinic again has suggested that NT-proBNP greater than 5,000 and troponin I greater than 0.1 should be excluded from stem cell transplant because treatment-related mortality is very high. I think I would agree with that statement for the community. I think because the stem cell transplant experience and success comes with, how many you've done. And I think that was the biggest disaster in IFM trial that was published in 2007 because treatment-related mortality was so high from the transplant regimen that the survival benefit was not there. But we also at Boston University also perform some functional assessment for patients who are on the fence as far as cardiac involvement. We do functional assessment by 6-minute walk test as well as a stair climb. We make them climb flights of stairs. And if they can do 3 to 4 flights of stairs, and we have them measured and whatnot, when we change buildings, we know exactly what stairs, and the steps has to be certain things, so it can't be any stairs, but it is done in a methodical fashion. And we also sometimes perform cardiopulmonary exercise study to really see what their V.O2 or oxygen uptake is. And that is how we decide whether this person will go through transplant in a without treatment-related mortality or significant morbidity. So that's the first question. The second question is about role of maintenance therapy. No, the second question is about induction therapy, achievement of a hematologic response, but the organ continues to deteriorate. And that is, again, unfortunate, and it does happen. It does not. So there are two. So again, when I did the talk in January, I had talked about what is the mechanism of clinical organ dysfunction in AL amyloidosis. The first mechanism is there is amyloid deposition in the organ, and it disrupts the architecture of the organ and leads to organ dysfunction, which is a very logical hypothesis that you have this foreign material sitting in your heart and heart cannot function. But there is also a lot of evidence from animal models, zebrafish, C. elegans, and cardiac myocytes of mice, that direct cytotoxicity of the precursor protein, the light chains, as well as of the soluble oligomers, can cause cardiac dysfunction. So if second, the latter is the mechanism of cardiac dysfunction, then you drop their free light chains and the cardiac function would improve. But if it is the first hypothesis that it is the amyloid deposition which leads to this cardiac dysfunction, then no matter what you do to the hematologic parameters, the cardiac dysfunction is going to progress. Again, I go back to our symptomatic management. It is crucial. I saw a patient this week who was on beta blockers. Beta blockers are poorly tolerated in patients with AL amyloidosis or cardiac amyloidosis for that matter. You do not want to do digoxin. No matter what people say, digoxin will not be tolerated in patients with AL amyloidosis and heart involvement. You do not want to do calcium channel blockers because calcium channel blockers can lead to significant hypotension and make patient feel worse. There is no higher upper limit for Lasix, for furosemide. For furosemide, if they have a lot of swelling and congestive heart failure, furosemide is not very well absorbed from the GI tract. Do torsemide, which is better absorbed from GI tract. I also feel spironolactone is underutilized. Spironolactone is a weak diuretic, but it is a vitamin for the heart because in laboratory, we've shown that it inhibits MMP, and MMP is at function in cardiac involvement from amyloidosis. So there are lots and lots of thigh-high stockings to improve the blood pressures. So again, in India, when you have 100 degrees Fahrenheit temperature, it is very difficult to put thigh-high stockings. But, we do that all the time to maintain blood pressure, to increase venous return. So I think symptomatic management is crucial. And the third question is about role of maintenance therapy. We don't know role of maintenance therapy. We don't do it generally. There's a clinical trial led by Heather Landau from Memorial Sloan Kettering ongoing of ixazomib maintenance therapy for patients with AL amyloidosis. The results are not out. The clinical trial is accruing. It is not close to accrual goal, so we will not have those results. Having said that, the Andromeda trial changed everything, because in Andromeda trial, it was Cybordi plus Dara, and the Dara was continued as maintenance after 6 cycles for a total of 24 months or a total of 18 months of maintenance. And that is what we use here in the United States of America because it is so easy to give subcutaneous Dara. And that is what I use. But I saw a patient this week from Miami who was stopped after 4 cycles of Cybordi Dara because he had achieved it. So I think role of maintenance is not known. For I think Reshma is gone from here, but for her patients with myeloma-associated AL amyloidosis, I would probably do maintenance therapy. But I think for AL amyloidosis alone, I think role of maintenance post-stem cell transplant is definitely not well defined, and I don't do it.
Wonderful. Thank you. Thank you very much.
Rajan, you be ready. One question from the audience. 70-year-old AL amyloid, severe autonomic dysfunction, systolic blood pressure is 80. What will be your best regimen to treat this man?
So again, I think I'm repeating myself 100 times. Supportive care is crucial. Guys, do not, blood pressure of 80, this person has very high mortality. So supportive care, and I have, we have electronic medical records, and I have a dot phrase that I just do, dot VS ANS, and it shows up, and it says behavioral modifications, change positions extremely slowly, count till 10 when you get up from laying position to sitting position to standing position. Avoid dehydration. I always ask them to carry some Lay's potato chips or wafers because that has so much sodium. So just pop some in if you feel dizzy. Third thing, thigh-high stockings, because that will increase venous return. Sometimes we give abdominal binders to increase venous return. Fourth thing, midodrine, which is an alpha-1 agonist. In male patients, be careful because there are a lot of alpha receptors in the urinary bladder. So it can cause urinary retention. So you have to gradually increase the dose of midodrine. Next thing, Florinef. If they don't have significant swelling, then fludrohydrocortisone, which is a mineralocorticoid, which causes sodium retention and can raise your blood pressures. The fifth thing is droxidopa. I have a feeling droxidopa is available. It's an old drug, but I think it is available in India. And I have a feeling it's probably cheaper than United States. But droxidopa, 100 milligrams 3 times a day, increase it to 200 milligrams 3 times a day. Again, these are all good measures. The treatment, I will not offer this gentleman bortezomib Velcade because Velcade or bortezomib can unmask autonomic neuropathy and can cause hypotension. So, you give them 1 dose of bortezomib, they are going to have episodes of syncope. I would probably suggest to do daratumumab, and I would probably suggest to do subcutaneous daratumumab. I have done it, and I gradually, I dose escalate rather than dose de-escalate. So I start with single agent daratumumab, and then if they are doing okay after 2-3 weeks, maybe do bortezomib, do it at 0.7 milligrams per meter square. If there is no worsening of hypotension, increase it to 1 milligram per meter square. If again, no couple of weeks, no increase in this, I increase it to 1.3 milligrams per meter square. So again, weekly bortezomib, never do twice a week bortezomib. It is not well tolerated.
Thank you. Rajan, your question. After that, Aditya.
Being an excellent as I heard your you must be having a special affinity towards cardiac amyloidosis. So I have a question that there is a high incidence of sudden cardiac death in cardiac amyloidosis, and it has been said that it is due to electromechanical dissociation. So we had a patient, cardiac amyloid, we gave Psy body, doing very well, and suddenly he passed away. Now the question which was asked, is there a role of implantable cardioverter defibrillator in cases of cardiac amyloidosis? Because if it is electromechanical dissociation, it may not help. So is there any role of that? And the second question is, supposing we have cardiac amyloid, we have given an induction therapy, went into a CR, are they candidates for cardiac transplantation?
Again, I'm amazed and I'm totally honored. You guys are all so amazingly involved in your patient care and, you know your patients. So great question. I lost a patient last weekend as well, who was in CR, 4 years in CR, was doing well. And he's sitting at the edge of his bed and wife comes into the bedroom and he's gone. So again, it's not, you are not alone in this. We all have experienced sudden deaths. You get attached to your patients. It's very heartbreaking. And specifically when they die in CRs. So role of AICD, defibrillator, transplantable, it's institution dependent. If you find non-sustained VTAC, I think you could twist the arm of the electrophysiologist to put a device in. But it has been shown over and over again that AICDs don't prolong survival in AL amyloidosis cardiomyopathy. Because as you said, that the cause of death is not VTAC, it is electromechanical dissociation. So again, I have a hard time convincing my electrophysiologist to put a device in for primary prevention. For secondary prevention, it is a little bit easier to convince them. I had a patient who was getting shocked by the AICD 4 to 5 times a day. And finally she said, just switch it off. I can't deal with this. and she died. So again, if it is VTAC related, maybe that can prolong your death, prolong your survival, but most of the times it's not VTAC related. The second question about heart transplant. So there are two issues. Advanced cardiac amyloidosis, you can't give them any induction or any treatment because they can't tolerate it. 10 milligrams of dexamethasone is going to put them in the hospital with congestive heart failure. 0.7 milligrams per meter square of bortezomib is going to cause significant cardiac output related issues and hypotension. So in those patients, we would, and if it is isolated heart involvement, so there are very specific criteria. If they have any other involvement, they will not touch the patient. They would do it for isolated cardiac involvement who are very, very sick with systolic dysfunction, left ventricular ejection as upfront. But you have to make sure that post heart transplant, once their immunosuppressive regimen is settled, so usually what I would do is 6 months after heart transplant is done, I would offer them stem cell transplant, but I have a very specific protocol to do it. If patient is reasonably okay and can handle Cybo-D or can handle Cybo-D DARA and then goes into CR, but the heart continues to deteriorate, you could, we've done it only in few patients like that, and they have remained in remission for 4, 5, 6 years post Cybo-D, post heart transplant, and have remained in remission, not required any further treatment. So, I think that again, heart is a very rare organ to get. So I think it becomes very difficult, and it is not on the heart transplant indication. AL amyloidosis is not. And sometimes I've had several patients die in ICU waiting for a new heart. So that, that the wait time is also, if it is very long and they can't find a heart, then, that is also a massive disaster. But again, it has to be done in conjunction with the transplant cardiologist, transplant surgeon, and obviously you.
Thank you, ma'am.
Aditi, your question, and then Dipankar.
Good evening, ma'am. Thanks a lot for the fantastic presentation. So I have two questions. So first one is related to last case that you discussed. So we had a similar case, a young male, I think he was 45 years old, who had typical features of AL amyloidosis with cardiac involvement. And we gave him VCD for 6 cycles, but there was lack of response, and his heart failure actually worsened and he died in hospital. And on autopsy, it was surprising for us to see AA amyloidosis in that case. So he had all the features like macroglossia, cardiac involvement, renal involvement, and obviously there was slightly increased plasma cells. So my question is, like, as you mentioned, there is a lag of 6 to 12 months between hematological response and organ response in classical AL amyloidosis patients. So what is your take on having a second look, especially doing a cardiac biopsy in such patients? So
I think that again, I think in India, I had said it in January when I give this talk, that I think in India, I get a lot of emails and whatnot, from patients, from caregivers, from physicians. And I always get a bit concerned because we have such high incidence of AA because of inflammation, infection, tuberculosis. We all have been exposed to tuberculosis. We all have positive PPD. We all have had BCG. So, again, the tuberculosis leading to AA amyloidosis is a real thing, and it is common. So I think it has to be kind of taken into account. I don't know how your patient's diagnosis of AA was obtained on autopsy, because serum amyloid A protein was probably tested by immunohistochemistry and not by mass spectrometry or not by something else. Immunohistochemistry relies on the antibodies and how good the antibodies are and how good you are at looking at those antibodies and the staining. So I think that it is very dependent on who's performing it. So, I would take that with a grain of salt. as you said, macroglossia is pathognomonic for AL amyloidosis. We have reported it that we've seen it in one person, several patients with ATTR variant or mutated ATTR amyloidosis as well, because it's a systemic disease. We do see AA amyloidosis, majority, 90% have renal involvement, liver, spleen, and kidneys. Those are the three organs involved with AA. In late stages in the game, heart can be involved as well. So I think those are the issues. I think that, as I said, 6 to 12 months for cardiac response is typical. I think you have to support them. I think, we want to rush and we want to be happy because we want to see cardiac response immediately, instantaneously, but it doesn't happen. And I think that one has to be, and again, the cardiac response may happen in 3 months or 6 months with 30% reduction in NT-proBNP. But if the NT-proBNP is 8,000, 30% reduction is, God only knows, math again, 6,000, 7,000. And that is still very high. So I think that these cases we all have seen that the organ, and that is why this is so challenging, unlike myeloma, where organs are not beat up. It's just the bone marrow that is beat up.
Fine. Thank you, ma'am. Ma'am, I have one more question. So out of all transplant eligible patients of AL amyloidosis that you encounter, how do you identify those who are not going to benefit from that?
Yeah, so I think it is basically all dependent on what your risk assessment is for treatment-related morbidity and mortality. And who do you exclude? Patient choice obviously is first. I'm having a hard time in the past year because of the Andromeda clinical trial results, because response rates are 90% and it's very easy to tolerate for renal-only AL amyloidosis patient who is 50 years old and doesn't want to go through transplant. Because it is, the way I try to sell it is that, again, I'm not myself convinced, but the way I try to sell it is that the long-term data is available for transplant, whereas long-term data for Andromeda is not yet available because median follow-up is only 14 months. We don't know 3 years down the road, everybody might relapse. We don't know that. So that is how I try to sell it, that it is a treatment which is for 2 years versus transplant, which is done and over with within 3 months. You are feeling better and, you are ready to go back to work. So I think that it is. So in our practice, our numbers have dropped because I'm unable to convince patients. And patients are very informed and educated so that it becomes very hard. And, there are lots of patient advocacy groups and support groups and this and that, and everybody is talking about Andromeda. So it becomes extremely, extremely hard to convince. But I think the exclusion criteria for us is low ejection fraction, poor performance status, elevated cardiac biomarkers, symptomatic pleural effusion that is refractory to medical management, severe autonomic dysfunction with systolic blood pressures of less than 90 in supine position, and also exercise or limitations of exercise tolerance. So we do the cardiopulmonary exercise test and all that. And then direct hyperbilirubinemia of greater than 2 milligrams per deciliter. So if they have liver involvement with elevated bilirubin, I will not transplant them because these guys, they have very high mortality.
Fine. Thank you, ma'am.
Thank you, Aditya. Dr. Deepankar and then Dr. Stalin.
So thank you, ma'am, for this excellent talk. I have two cases. There is a 48 years old female who was diagnosed with systemic lupus erythematosus in 2020. So she was started on hydroxychloroquine at that time, and she had also had an interstitial lung disease for which she received steroids. She also had a history of carpal tunnel syndrome 3 years back. So now she presented this year with generalized anasarca, breathlessness, occasional dizziness, and postural hypotension. On examination, she had hepatomegaly and macroglossia. So I did a serum protein electrophoresis that showed an M band of 0.6. IFE showed IgG lambda, and this kappa lambda ratio was 0.2 and a DFLC of 278. Proteinuria was there, which was around 900 mg per day, and an NT-proBNP was 1540 picogram per ml, and a high TROP-I also. So that was a cardiac stage 3. Bone marrow was done that was showing 12% plasma cells, but the Congo red staining was negative, and a subcutaneous fat pad aspiration also showed a negative Congo red staining. So, seeing the clinical picture without a definitive diagnosis of amyloidosis, I started on Velcade and Dexa. She received for 6 cycles. Her anasarca definitely got better, and her troponins and cardiac biomarkers also reduced some more than 30%, and a proteinuria also like reduced more than 30%. So there was a response, but the DFLC was like less than 50% response. So this was no response. So like what should be done in such a case, ma'am, where there's some organ response, but there is no hematological response, and like what can be done further? Any maintenance in such a case?
Excellent, difficult question. I know I just want to make sure that the diagnosis of SLE is correct, that it was not all part and parcel of AL amyloidosis, because which happens, that they could have some, biomarkers or ANAs, which is elevated, and which we can see it in many other conditions. Congo red stain is a very fastidious stain. Unless you have it set up correctly, and unless you keep doing it multiple times, it is very, very easy to get false positives and false negatives. So, across town at Harvard hospitals, they have not been able to set it up. They always get it false negative, or they always get it false positive when they come to us, when we do it. So again, I think Congo red stain has its own limitations and whatnot. I think it seems that your patient does have AL amyloidosis. And I think that the question is, so when I talked about organ responses are seen with all sorts of hematologic response. And hematologic complete response is not always needed to have an organ response. If patient has achieved an organ response with hematologic PR, I think I would probably say that close follow-up and active surveillance are the best to do, because by the time she will relapse at some point. He will relapse at some point. And when that happens, at least the organs are in better shape. And maybe you would be able to transplant this person, or maybe you can do further treatment with higher doses of Velcade or higher doses of dexamethasone or whatever. But I think that let the organ recover. Let her recover from the toxicity, morbidity associated with Velcade dex. And I think that would happen. Active surveillance is critical. Do not let her get lost to follow-up. Make sure that these numbers are checked every few months and things like that. But I think that, hematologic PR can lead to organ responses. CR is not a prerequisite.
Ma'am, my next case is, it's a 70-year-old non-diabetic gentleman who presented with a 1-year history of peripheral neuropathy, like bilateral, both feet were involved with a sensory neuropathy, along with some altered bowel habits, and autonomic neuropathy was also there. So he was taking gabapentin for the past 1 year. A neurologist did a serum protein electrophoresis, which showed an M band of 1.3 gram, and a immunofixation showed IgM lambda. Kappa lambda were normal, like kappa was 38 and lambda was 32. Urine, also kappa lambda was like 7 and 3, and kappa lambda ratio was 2.3. Beta 2 microglobin was 995. IgM was raised in the immunoglobulin profile, and IgG and A were reduced. And a 24-hour urinary protein showed 300 milligrams per day of proteinuria. Bone marrow was done, but we could not do the biopsy because he was very apprehensive, and aspirate was also came out to be inconclusive. So that was a problem at that time. A fat pad aspiration was done, that was Congo red positive. MRI of the heart was normal, and 2T echo did not show any diastolic dysfunction. The troponins were like, this was coming under the stage 1 Mayo staging of the cardiac amyloid. And so, ma'am, in this case, should we consider it first as AL amyloid or not? Because the typing was not done. Only the thing was like neuropathy, autonomic as well as peripheral neuropathy, and like it could be a hereditary thing also or not. So just what should we do in such a case?
Right. So I think that this is obviously, I would not call him AL amyloidosis just based on what you have. I also will tell you that we have several patients of Indian origin in United States who come to see us with similar symptoms, and they have ATTR mutant V30M mutation, which is a mutation that is very common in Portugal. And in Portuguese people, it is, Portuguese and Sweden. Those are the two countries that have this mutation. And I think that we see a lot of them because of, the Goa and the colonization and all that. So I think that we have several patients who are Indian, but they have V30M mutations. And, again, that goes back to our history. So I think that I would definitely try to at least do a TTR genetic testing to see that, and the clinical phenotype of ATTR mutant V30M is neuropathy. And in late stages, they get cardiomyopathy. So I would, and they can have they can have fat pad positive. So fat pad is positive with Congo red staining in about 75 to 80% of patients with systemic AL amyloidosis. It is positive in about 50% of patients with ATTR mutant amyloidosis, and it is positive in about 15 to 20% of patients with ATTR wild type amyloidosis, which is the senile cardiac amyloidosis. So I think that is what I would do is, try to get a TTR genetic testing just to make sure that this is not V30M rather than treating him.
Ma'am, in such a case, such amyloidosis, ma'am, should we think about in a myeloma, we think about bone disease. So in amyloidosis, is there a role of bisphosphonates?
No, unless there are because amyloidosis, AL amyloidosis does not usually cause bone lesions. So we don't do bisphosphonates. But if, like Dr. Ishma's patient with multiple myeloma associated AL amyloidosis, yes, there would be role for bisphosphonates. Again, be careful because their kidneys are not normal. So if kidneys are not normal, use bisphosphonates accordingly. Not, it can affect the kidneys otherwise.
Thank you.
Thank you, Dipankar. Dr. Stalin and then Aniket.
Thank you, madam. Thank you very much for that lucid talk and all the questions you are answering. So just a general question, madam. For the cardiac MRI is actually diagnostically challenging and many are not able to report in my setup. So does all patients of AL amyloidosis need a cardiac MRI at presentation? If not, are there any specific indications for getting a cardiac MRI at baseline? And another question is for a patient who had only proteinuria, which is in the nephrotic range of proteinuria as only manifestation, after the transplantation, how often do we need to monitor with the 24-hour urinary protein? How frequently we need to check for the 24-hour urinary protein in those patients?
So I'll take the second question first. So 24-hour urine protein for patients with AL amyloidosis who have achieved a hematologic response. We measure them once a year. So first year of transplant, they come back at 6 months and then 12 months, and then they come back annually if they have had normal or if they've had a complete hematologic response. Because the organ response, it is not going to go down. I think every 6 to 12 months is a reasonable choice. Indication for cardiac MRI in patients with AL amyloidosis. I think that with the advent of cardiac biomarkers, I think the role of cardiac MRI is really, really not there. If you can diagnose AL amyloidosis with other parameters, tissue biopsies, and have, whatever renal involvement, I think that MRI is not going to change your management. If you have elevated cardiac biomarkers, low voltage on EKG, left ventricular hypertrophy with thick IVST by echo, I think you have cardiac involvement. That is not going to change your management if you get a cardiac MRI. I think in some patients who have myeloma and who are feeling short of breath and fat is negative, and you can't figure this out why they are so short of breath, and echo is IVST is about 11, there is some diastolic dysfunction, you are not 100% sure. In those cases, maybe there's a role. We do probably 1, 2, 3 MRIs a year. It's not really routinely done. So I think the role of MRI is, again, there are a lot of studies that have come out which are showing that the extracellular volume in cardiac amyloidosis with MRI is the first to improve post hematologic CR. So again, there may be a role for it in assessing the quickness of organ response, but not really as diagnosis.
Thank you, ma'am.
or even not even for prognosis for that matter.
Thank you.
Thank you, ma'am.
Dr. Aniket, your question, then Dr. Govind.
Good morning, ma'am. Thank you, sir. Thank you, ma'am, for the talk. I have three questions. Amongst the three classifications or the criteria for the Boston, the Mayo 2002, 2004, and 2012, which would you prefer to classify them? The second question is in organ-specific or organ-limited amyloidosis like renal and liver. Your colleagues from nephro or hepatology are wanting to do a renal or a liver transplant as well. So when do you put a bone marrow transplant and a liver transplant or a solid organ transplant along with it? And the third is in MGUS or in patients with smoldering multiple myeloma, there's no other evidence of amyloid, but the bone marrow biopsy shows amyloid involvement. So how do we treat them, or do we just observe them?
Okay, so I think I'm getting old. I forgot the first question, but that's that's okay. So the second question was okay, I forgot the second question too.
The second
Okay.
question was like for renal limited or for liver limited amyloidosis, when do you place solid organ transplant, and do these need bone marrow transplant, and when?
Right. So for solid organ transplant, specifically for renal transplant, there's a huge paper that I will send it to Dr. Agarwal, which is kind of showing the responses. It's an international effort from all the centers, about 250 patients. Again, what it has shown is that the renal transplant, so we perform plasma cell directed therapy, and if they are in hematologic complete response, and they maintain a hematologic complete response a year after therapy, off therapy, and now their kidneys are failing, those patients should be evaluated for renal transplantation. Liver transplant in AL amyloidosis is performed only in case-based series. Again, livers respond very well. So if you have treated somebody and have gone into complete hematologic response, there is no reason to perform a liver transplant because the liver is going to regenerate. The alkaline phosphatase, which is 1500, is going to go down to 100 and 120 and 200 over next 2 years. Liver transplant as initial therapy should be performed if you have a bilirubin, which is 5, 6, 7, 8, and now you can't even give them bortezomib because that is excreted hepatically. So yes, but then again, you have to be careful because you don't want to put somebody through a solid organ transplant where they have multi-system organ involvement. You have to have isolated organ involvement to do solid transplant. So that was the first question. The second, what was the last question, which I thought I remembered?
It is if you have just an isolated amyloid deposits in
the bone marrow, right.
In the bone marrow with a smoldering myeloma
right.
an MGUS.
Right. So smoldering myeloma, MGUS with isolated bone marrow involvement, please make sure that this person does not have organ involvement because, it is difficult or not, it is easy to miss organ involvement. You have to do a proper physical exam, orthostatic vital signs to make sure that they don't have autonomic neuropathy. Erectile dysfunction could be the first symptom of autonomic neuropathy. Gastroparesis, unintentional weight loss, these could be the first symptoms. Obviously, 24-hour urine collection, echocardiogram. I think this patient, I would do a cardiac MRI. So I know that there was a question initially, but I think this particular patient, I would do a cardiac MRI if echo is not suggestive of cardiac involvement, because you are going to base your treatment or decision for active surveillance based on organ involvement. Okay, and the first question was?
The first question was, which amongst the classification of Mayo?
Oh, yes, yeah. Right. So there are 3 staging systems, Mayo 2004, Mayo 2012, and BU 2020. So we developed our staging system, which is to validate what Mayo had done because we did not have access to perform NT-proBNP. So there are a lot of institutions in the United States where it is only BNP that is being performed. So that is the reason why we developed it. And we proved that, yes, it is similar to with different, obviously different thresholds. Yeah. Between Mayo 2004 and 2012 staging system, Mayo 2012 staging system incorporates the markers of plasma cell dyscrasia, which is the involvement DFLC levels. Yeah. And Mayo 2004 is very good in predicting survival. So, with the European subclassification of stage 3B. So 2004 is very good in predicting survival, like immediate survival. Whereas Mayo 2012, which we generally don't use, we are using only Mayo 2004 because we feel that it is such a powerful tool in predicting survival. And 2012 does have plasma cell dyscrasia markers as part of the staging, but now we have such powerful treatment for plasma cell dyscrasia that we also feel that, DFLC of greater than 180 is, it's going to go down with data right away. So then, so I think 2004 is what we are using generally, even for clinical trials and everything else. But, again, both the systems are, they are very, very discriminative in predicting survival.
Thank you.
Thank you. Dr. Govind, if you have more than one question, ask one question at a time.
Yes, thank you.
Yes, Govind, go ahead.
Thank you, Dr. Vaishali, for your very, very excellent presentation. And my first question is, as we know that the majority of the cases underlying clonal disorder is plasma cell disorder. At your center, what % of the cases of the amyloidosis you will encounter the clonal disorder other than the plasma cell, like other B cell disorder like lymphoplasmacytic lymphoma or marginal zone lymphoma, and how do you manage them?
Excellent question. 3 to 5% of patients would have B cell lymphoproliferative disorder associated with AL amyloidosis. Most of the clinical phenotype is renal involvement, nephrotic syndrome, sometimes cardiac involvement. Majority are predominantly renal involvement, and the treatment is usually directed towards the lymphoproliferative disorder. So if it is, Waldenstrom's or lymphoplasmacytic lymphoma in the bone marrow, I would probably do Velcade BDR regimen, Velcade, Dex, Rituxan, 4 cycles. And if they've had a response, then take them through transplant. If it is, we've also used Arbenda. If patients are not transplant eligible, then I've used Arbenda in patients with CLL or also B cell lymphoproliferative disorder. So attack the clone is the goal. Mm-hmm.
Thank you, ma'am. And my second question is there any role of the antifibril antibody at present scenario in AL amyloidosis?
Clinical trials are ongoing. Is it hope or is it hype? I don't know. I have very strong opinions about it and I will not share it. But, so that the first antibody trial was NEOD-001, which was a drug made by Prothena. And there were 3 clinical trials. And the whole development of that program stopped after interim analysis because of futility, that it did not work. The Pronto trial was a phase 2B trial and Vital trial was a phase 3 trial with placebo-controlled arm. And it did not really change anything. There were a lot of criticism about the trial because the endpoints were not designed appropriately. There is a new antibody called Calum 101 or 11F4, which is undergoing clinical trial evaluation currently in newly diagnosed patients with advanced cardiac amyloidosis with CyBOR-D plus DARA plus or minus Calum 101. We don't have the results, so we will wait and see. And then the GlaxoSmithKline, which was the New England Journal of Medicine paper from UK National Amyloidosis Center, Dr. Pepis, was an antibody directed towards the SAP. And that, first 5 patients they reported in New England Journal of Medicine. Oh my God, phenomenal results, excellent. But on a clinical trial, when they did it, they had to stop it after 2 patients because they haven't really told anybody why they ended up stopping. But the word on the street, the rumor on the street is that the patients didn't do well and they passed away from a massive pericarditis/aortitis because it was a monoclonal antibody that caused a lot of inflammatory reaction. So we don't know, but I think we'll have to wait and see what these clinical trials show.
Thank you, ma'am.
Dr. Govind. Dr. Ashok, your one question at a time. Ashok.
Good evening, ma'am. Thank you very much for fantastic case-based discussion and answers to all questions. We all are benefited. My question is regarding your third patient that regarding cardiac transthyretin amyloidosis. So this technetium pyrophosphate scan used to differentiate between cardiac transthyretin amyloidosis and light chain amyloidosis. My question is regarding this scan. Do you do it at your center or practice? And how do you interpret the results? Because few times it is false positive in light chain amyloidosis also. So that is my question.
Excellent question. We do it all the time at our center. We have done it about 300, 350 pyrophosphate scans. So there are two types of bone tracers, radionuclide materials. We do technetium pyrophosphate. In Europe, they do DPD. So which is two different types of bone tracers. In US, we do pyrophosphate. And it is commonly positive. There is a heart to contralateral ratio and there is a Perugini visual score. So if it is Perugini visual score is greater than 3 or heart to contralateral ratio is greater than 1.5, it is highly suggestive of TTR amyloidosis. 10% of patients with AL amyloidosis and cardiac involvement can also have positive PYP scan. I think it is crucial because it is very difficult to interpret these scans. And you have to have a nuclear cardiologist who knows how to interpret. There is also timing related issues. You have to scan them at 0 minutes, 1 hour, 3 hours. There's a lot of blood pool scanning. You have to have a SPECT associated with this scan, which gives you the Perugini score. So there are a lot of nuances about this scan that, I'm not a nuclear cardiologist. I rely a lot on Dr. Rick Ruberg, who's in our group, who's a nuclear cardiologist. But these things, I think, have to be properly done because otherwise it's very easy to say is false positive or false negative.
And my second question is, if patient of AL amyloidosis and after a treatment of 3 to 4 cycle is responsive and there is negative serum protein electrophoresis and immunofixation, however, patient is having persistent proteinuria of 2+, 3+ around. So up to how many cycles do you wait for plateauing the response and otherwise escalating the therapy or?
Right. So again, organ response is going to lag behind by 10 to 12 months. So that's not the issue. I think you have to prove that he's totally in complete hematologic response. And generally, so, some patients go into hematologic response with 1 dose of daratumumab, with 2 cycles of Cyborg-D. And, and then you wonder whether you should continue, not continue, what to do. Usually I have done 4 cycles. So 4 to 6 cycles. I always say it's 6 to 8 cycles, but stop after 4 if hematologic CR is achieved. But make sure that CR is achieved, that you check urine, not just check SPEP, UPEP, because SPEP, UPEP are not good. You have to do the immunofixation electrophoresis. And I actually complemented the bone marrow so that, I know that the bone marrow is negative too. What we have not discussed in all these question answers, or even in my presentation, is the role for minimal residual disease achievement. So I know that in Ahmedabad, oh God, I forget his name, Supratek. What's his name? What's his name? Sandeep. So Sandeep Shah. So his son is actually, he was a fellow with me and now he's a faculty at Dartmouth. But Parth and, so he tells me that, we can do everything at Supratek. So, they do have ability supposedly to do a minimal residual assessment with the help of next generation flow, multi-parametric next generation flow. So so in myeloma, yes, that is taken over everything. In AL amyloidosis, we are not yet there. We may be there in 5 years, 10 years, because, we are dealing with 2 diseases, bone marrow, plasma cells, and the organs. So we don't really know. We've published a lot on this and we have an ASH abstract coming up as well. But it is very unclear that we have patients who are MRD positive, have had beautiful organ response, and they remain MRD positive 20 years post-stem cell transplant and with no proteinuria and leading a normal life. But they are MRD positive. So what does that really mean? So, we didn't discuss that, and I wanted to bring that up because I didn't want to have it in my talk, but I do not change therapy based on MRD assessment.
Thank you, ma'am. Thank you very much.
As you be ready with your question. One question from the audience. What is your experience with bendamustine, carfilzomib, pomalidomide regimen? bendamustine, carfilzomib, pomalidomide?
Oh my. So it's a great question, but no role. So, as I keep saying, AL amyloidosis patients are tricky. They are difficult. Their organs are beat up. Doing less is better till the organs respond. Carfilzomib was studied in a phase 1 trial. Adam Cohen was the principal investigator from Penn. We enrolled several patients on the trial. That has not been reported yet, but he did present this as an oral presentation at ASH in 2018. 36% of patients had grade 3-4 cardiac events with carfilzomib single agent. Again, in relapsed setting. So in first line setting, I think it's going to be even more. So I don't really recommend carfilzomib. ASHU has published a small series from UK National Amyloidosis Center of carfilzomib in patients who have significant peripheral neuropathy, who cannot get bortezomib-based therapy. And he has shown that, it was well tolerated. Again, you have to manage them very carefully. And most of the patients in that series did not have heart involvement. So renal toxicity, cardiac toxicity remains an issue. Carfilzomib, bendamustine, and PALM was the question, right? So again, I think bendamustine has been, I was not really impressed with that clinical trial. I had about 4 or 5 patients on that trial out of 28 patients. Dr. Suzanne Lynch was the principal investigator. And, bendamustine is in relapse refractory setting. What I found was that the hematologic responses were not really great, 11% CR. But it was toxic. First 2 cycles went very beautifully. And then fatigue was a massive issue. It was not myelosuppression, fatigue. Patients just felt that they were bedridden for, 80% of the time. So I think that, that fatigue with bendamustine is, and PALM actually I like the best out of all immunomodulatory agents, because PALM is very easy to tolerate. The maximum tolerated days and maximum tolerated dose in our clinical trial for PALM in relapsed AL amyloidosis was 4 milligrams, 3 weeks on, 1 week off. So similar to multiple myeloma, unlike lenalidomide, when maximum tolerated dose is 15 milligrams and not 25 milligrams. So I think PALM is very well tolerated. Responses are quicker. Median time to hematologic response is 3 months versus 6 months for lenalidomide. So I think PALM, I wouldn't take PALM off. I think PALM is easy. Obviously, remember, you have to put them on aspirin for thromboembolic complications and prophylaxis. And if patients have GI involvement, please make sure that the aspirin is given with PPI, proton pump inhibitor, and things like that.
Thank you. Dheeraj, your question, then Deepak.
Yeah, good evening, Dr. Vaishali. Thanks for this excellent overview. I am basically from the internal medicine background, so I learned management of orthostatic hypotension. The question will be long, but the answer is very brief and it's single question only. Regarding this cardiac biomarkers, you told one of the person said that we don't have availability for cardiac MRI, but then you said that biomarkers are good enough, and the staging system, especially 1 or 2 cases you showed with normal renal function and another with abnormal renal function, and you know very well the NT-proBNP, BNP levels go high with them. So we have these good markers which we are using, ST2, that is soluble ST2 receptors. We are not using GDF50, but for heart failure, even for this, I think AL amyloidosis, it will be a good biomarker. Even with renal involvement, you don't have to have different cutoffs. And maybe you can come up with Boston 2021 with ST2. I'm just saying. So just this thing, your role about the newer cardiac biomarkers, especially soluble transferrin, soluble ST2, and will you monitor them like 3 months, 6 months? As you said, the organs will take 6 to 12 months for their improvement.
So, the great question. We did not have NT-proBNP, and, you're absolutely right. Both the BNPs, NT and BNP itself, they do have, they are hard to interpret in patients with renal failure. I think that, we have shown it, Mayo Clinic has shown it that BNP is a little bit better to interpret with renal failure than NT-proBNP is, but it does remain a challenge, no question. And I think then we take the entire picture into account, including echo and the EKG and obviously the symptoms of the patients. And sometimes we say biomarkers hard to interpret, patient may have cardiac involvement, but cannot be proven. it is not going to affect our treatment decision if they have other organ involvement. And I would be very happy. And, again, I think that we need some biomarkers, which are novel biomarkers, which are not affected by the renal function. And we usually check them every 3 months or every, so again, there are a lot of folks in the community or in our, in amyloid community where they change treatment if cardiac biomarkers are not responding, meaning that they check them every month or every 2 months or every 3 months. And if they are not responding, then they would change the primary plasma cell directed therapy. I'm not yet there for that because BNP goes up if you have a Chinese meal. BNP goes up if you have a bag of wafers. BNP goes up if you have a canned tomato soup, because it is a lot of sodium. So I'm not really convinced that that really affects it. So I don't really change it based on just cardiac biomarkers. But we do know that response in cardiac biomarkers does translate into overall survival benefit. So, again, I think that we usually check it every 3 months.
What about the soluble ST2?
Right. So I don't have any experience with soluble ST2.
Because that is it's most precise and most important. With renal failure, it's not affected. So it will be more useful. That's what I thought. Maybe you all can do the next research with ST2.
Thank you.
Yeah, I'm getting old.
Thank you. Dr. Dipankar.
Ma'am, how much in a case of amyloidosis, how much does a urinary protein electrophoresis or a urinary immunofixation add in addition to this like serum immunofixation or a serum protein electrophoresis? Because during in the diagnosis and response, we can assess the urinary parameters through proteinuria. So how much does it add to this, the urinary fixation and urine protein electrophoresis?
So that's another good question. I think that, again, the evaluation of plasma cell dyscrasia in AL amyloidosis, 80% of the patients are going to have elevated abnormal serum free light chain assay, 80 to 85%. There are 15 to 20% of patients who would have them normal. Similarly, urine immunofixation electrophoresis, not UPEP, urine immunofixation electrophoresis is positive again in 80 to 85% of patients. Serum immunofixation, so you do see sometimes that serum immunofixation is negative, but urine immunofixation will have lambda light chains or IgG lambda or whatever, the monoclonal protein. So I think that, at diagnosis, you must do urine immunofixation electrophoresis and then for response assessment. If at diagnosis urine immunofixation electrophoresis is negative, then you may not have to repeat it at the time of response assessment. But I think that at the time of diagnosis, if specifically SIFE is negative, UIFE, there's a good chance that it's going to be positive.
And ma'am, in a case, ma'am, you told in a case of multiple myeloma associated with amyloidosis, ma'am, if there is a plasma cell burden, like myeloma has a plasma cell burden, so what type of maintenance do you prefer? Like bortezomib based, because lenalidomide or thalidomide, they cannot tolerate. So bortezomib based maintenance, only bortezomib can be preferred in such a case?
Right. So it's again, I think bortezomib, I would use it only if they have high risk cytogenetics for myeloma, but otherwise lenalidomide, maybe even 5 to 10 milligrams if they can tolerate it. I know it is very difficult to tolerate len for AL amyloidosis, but if they just cannot tolerate it, then maybe doing bortezomib and maybe even ixazomib. I know that Tourmaline 3 trial, MM3 trial, did show some advantage, but not an overall survival advantage. So.
Thank you.
Last question, Aditya.
Ma'am, my question is regarding upfront use of DARA in AL amyloidosis patients. So how do you counsel the patients who do not respond optimally to upfront DARA? Is it bad, terrible, or just okay as far as response to future therapies are concerned? So that is one question. And
let me answer the first question before I forget the first question.
Thank you.
It's you feel that but it is definitely as you become double digit, and then it does affect what you can remember. But anyway, so so single agent DARA. The question is whether you're doing single agent DARA or are you doing VCD DARA or CyBorD DARA. So I think that in Andromeda, CyBorD DARA, newly diagnosed patients, 92%, 60% had hematologic complete response, 92% overall response. So you have 8% of patients who are not going to respond, so which is a very handful of patients. If you are doing single agent DARA because the patient has bad heart involvement, you do not want to give bortezomib, and you are doing just single agent DARA, most of the times patients respond because it has not been studied in single agent in upfront setting. Most of the times, if they don't respond, which is, handful of patients, I would gradually try to add bortezomib-based therapies. First, just do one thing at a time, which would be bortezomib starting at 0.7, 1.0, 1.3, and see if you can convert them into a hematologic response. If none of them have worked, CyBorD DARA, which is again handful of patients, but I think it happens, I think it is difficult. So I've had several patients, and then my go-to regimen is POM. I'm looking at my data currently because see, the issue is translocation 1114, which is present in 50% of patients with AL amyloidosis. We have shown it, Europeans have shown it, that bortezomib does not have great responses in patients who have translocation 1114. They respond better with alkylating agents. We obviously do not have venetoclax, or we don't have data on venetoclax to really use it. So in those patients, we know that melphalan-based or alkylating-based treatments are better. We did show in all the trials, including Andromeda, that DARA can overcome the bortezomib-induced resistance with translocation 1114. But I think if you have a patient who has not responded to CyBorD DARA after 2 or 4 cycles, I think the question is, can he tolerate melphalan? And can we do high-dose melphalan stem cell transplant? And, has he had bad heart and that's why we can't do it? Or does he have renal only and the patient chose to get treated with CyBorD DARA? So I think that, we have used venetoclax in several patients, and it is beautiful. They respond right away, and I just do 100 milligrams. I start with, and there is no, just like myeloma, there is no tumor. So I'm actually on an inpatient service right now. So I have 3 patients with CLL who are getting venetoclax ramp up do you guys have venetoclax in India or no?
We get it.
Oh, I'm telling you, India has everything. No, absolutely. So if you have another, so, we know that for CLL, we have to do a ramp up because tumor lysis is so high and we admit them to the hospital. So I have 3 patients currently who are doing ramp up in the hospital, and in myeloma, there's no tumor lysis. So we don't really do ramp up for myeloma. Similarly, for AL amyloidosis, I start them at 50 or 100 very low doses, and they all respond. But they have to have translocation 1114 to respond. But I obviously know first-line therapy, first-line would be DARA. I know our paper is coming out soon, where we've looked at 100 patients who were treated with daratumumab, either as single agent or in combination. And what we found was that on a multivariate analysis, that the negative predictive factors were gain 1Q, obviously NT-proBNP greater than 8,500, and the duration of treatment. So patients who got less than 12 cycles versus greater than 12 cycles, did better with overall survival and major organ deterioration progression-free survival. Again, it's not a randomized trial. It is a hodgepodge of all retrospective data. It is not a prospective trial. So those are going to be the issues. But I think longer duration is probably, and that's what Janssen recommends. I don't really know whether they recommend it from the financial perspective or whether they are recommending it. But I think in India, if DARA, Dr. Agarwal was telling me that it is 25 lakhs of rupees for 6 cycles. Oh my God, I will never, ever be able to afford DARA in India. I don't know how patients do it.
Okay. Are we left with any questions? So this marathon session comes to an end. I must appreciate your patience. I thought at many stages that you will stop it now, but you answered almost everything. Now the faculty is not left with any questions. So thank you so much. First of all, you accepted the invitation, you were with us, what a brilliant talk, and then patiently answered everything. I think everybody has benefited, and the care of the amyloidosis in this country will be very different. Thank you so much. And have a wonderful
It is an honor and pleasure to be here. Absolutely delighted to be here, and good to see you all on Zoom, and hope to meet you all soon as well. Thank you and good night. And thank you for spending your Saturday evening with me. For us, it is just Saturday morning, so that's okay. I have the whole day.
Dr. Manoj around?
No, sir, he is not there.
That's it. That's the end of it. Thank you very much.
Thank you. Namaste.
Namaste.
Thank you.